Hey class, it's me, Dr. Jenkins. This lecture, we're going to be talking about cardiac output and myocardial ischemia. These are the learning objectives. We're going to be going over a lot of stuff in this module. And the first thing we need to do is define cardiac output. So cardiac output is the amount of blood that is pumped into the aorta each minute by the heart. And you can calculate it by taking the heart rate and multiplying that by the stroke volume. And you can calculate the stroke volume by looking at the difference between the end diastolic volume, so the amount of blood in the ventricle at the end of diastole, and you subtract the end systolic volume, the amount of blood at the end of systole. So if you have a left ventricular end diastolic volume of 120 milliliters and a left ventricular end systolic volume of 50 milliliters, then your stroke volume will be the difference between the two, so 70 milliliters in this case. Now the ejection fraction is the ratio of stroke volume and the end diastolic volume, so the amount of blood that actually leaves the ventricle divided by the amount of blood that was in the ventricle at the end of diastole. And so in this case, if we take our stroke volume of 70 milliliters and divide by the left ventricular end diastolic volume of 120, we get an ejection fraction of 58%. And a normal ejection fraction is anywhere from 55 to 70%. So there are three main physiologic variables that can affect the stroke volume. They are preload, afterload, and contractility. And we're going to talk about each one of those individually. So for any muscle, preload is the degree of tension on that muscle when it begins to contract. So the more the muscle fibers are stretched before the contraction, the greater the force of contraction will be. For the heart, preload is the ventricular wall tension at the end of diastole, which is determined by the amount of blood that's in the left ventricle prior to contraction. And we approximate this by the end diastolic volume, and sometimes we use the end diastolic pressure. And this is mostly determined by venous return, so how much blood is returning through the veins to the right side of the heart. Now, when we talk about preload, we got to talk about the Frank-Starling law. And I'll be honest, for the longest time, I thought that Frank Starling was one person. But in fact, it was two different scientists who discovered the same principle. So the first was Otto Frank, a German scientist who also developed much of the work that became the Wigger's diagram. And then Ernest Starling was from Great Britain, and he discovered a lot of different things, hydrostatic and oncotic pressures, which became known as Starling forces. He also invented the term hormone. So what is the Frank-Starling law? Well, according to Otto Frank, he said that within physiological limits, the force of contraction is directly proportional to the initial length of the muscle fiber. So what that means is that when extra blood flows into the ventricle, cardiac muscle is going to be stretched to greater length. And that's going to improve the overlap of actin and myosin filaments, which leads to a greater force generation. So if more blood goes into the left ventricle, it stretches more, and it's going to have a greater force of contraction, which is going to generate a larger stroke volume. And what that means is that the heart is able to automatically pump whatever amount of blood comes into the ventricle. The ventricle will accommodate that amount, it will stretch more, and it will pump all of that blood out. So here is a cardiac output graph, and on the y-axis you see ventricular output. It will often say cardiac output in liters per minute. And on the x-axis you see atrial pressure, which increases as you fill the atrium with more blood. So as preload goes up, atrial pressure goes up. And you can see from the red curve that as the ventricles fill in response to higher atrial pressures, each ventricular volume and strength of cardiac muscle contraction goes up causing the heart to pump increased quantities of blood into the arteries. So if we have this spot here on the cardiac output curve, atrial pressure of about 2 millimeters of mercury and a cardiac output of 5 liters per minute. If we increase the atrial pressure and increase the preload, now we say up to like 6 millimeters of mercury atrial pressure, that's going to increase cardiac output to like 12 liters per minute. But that force of contraction, will plateau eventually. You can only fill the heart so much. So when we get it to higher atrial pressures, higher amounts of preload, eventually you reach a plateau where it can't increase cardiac output anymore. This relationship is also shown in this pressure volume loop where the LV volume is on the x-axis and LV pressure is on the y-axis. And you'll see in the red loop here that as left ventricular volume increases, you have a higher left ventricular end diastolic volume. The ventricle will stretch and eject that blood more rapidly. And because the end systolic volume is the same, the net effect is that you have a larger stroke volume. So you can see this wider red loop here shows that you have a larger stroke volume with higher preload. Whereas in the green loop, you have a lower stroke volume because you have lower preload. So things that increase preload would be adding more volume to the system. So that could be in the form of a blood transfusion or giving someone IV fluids. If you slow the heart rate down, it actually has more time in diastole, so more filling time, and that will increase preload. And then if you activate the sympathetic nervous system, it will constrict veins. And if you constrict veins, which is a large reservoir of blood, you can actually increase the amount of blood that returns to the heart. So then the things that decrease preload would be anything that removes volume from the system. So that could be a medication called a diuretic that increases urine output, dialysis where you're actually removing fluid and volume from the blood, or like if someone was bleeding. If you increase the heart rate really fast, like to the 200s, you can decrease filling time enough to affect preload. And then medications that dilate veins, like nitrates, such as nitroglycerin, will also decrease preload because if you dilate these large veins and you trap blood in the venous side of the system, you're not going to have that blood returning to the heart. So that will decrease preload. All right, let's talk about afterload next. So for any muscle, afterload is the load against which the muscle exerts its contractile force. So for the heart, afterload is the resistance that must be overcome for the ventricle to eject its contents. And we usually approximate afterload by systolic arterial pressure or mean arterial pressure. And afterload you can also think about as being mostly driven by systemic vascular resistance, which is controlled by the arterioles. So here's a cardiac output curve with cardiac output on the y-axis and right atrial pressure or end diastolic volume, which are similar to preload on the x-axis. And you see here this black line is normal. And so this green dotted line is showing that if you decrease afterload, you decrease that resistance that the heart has to pump against, it will increase cardiac output. Whereas if you increase afterload, you increase the amount of work that the heart has to do, it's going to decrease cardiac output. And that relationship is shown here again in a pressure volume loop. So again, you got LV pressure on the y-axis and LV volume on the x-axis. And you can see in the red loop that as you increase afterload and you increase the pressure that needs to be overcome during contraction, during systole for blood to leave the heart, you're going to have less time for blood to leave the heart. You're going to have a lower stroke volume. So you're going to decrease cardiac output. Whereas if you decrease the pressure, the resistance needed for blood to leave the left ventricle, like you see here in the green loop, you're going to have a larger stroke volume because it's easier for blood to leave the left ventricle. So what affects afterload? So if you increase afterload, you're going to decrease your stroke volume, anything that raises arterial pressure. So you give medications like vasopressors that bring up blood pressure, that is going to decrease your stroke volume. If someone has uncontrolled hypertension, really high blood pressures, that's also going to uh, increase afterload and decrease their stroke volume. The other thing that would increased afterload would be an obstruction to outflow. So if you have a really narrow aortic valve, aortic stenosis, or if you have a condition like hypertrophic cardiomyopathy, which can lead to valve obstruction, that's going to increase your afterload. And then anything that increases total peripheral resistance is going to affect afterload. Now, if you decrease afterload, that's going to increase your stroke volume, and this is anything that lowers your mean arterial pressure. So if you give someone medications for hypertension, going to bring down their blood pressure, that's going to improve their cardiac output. Vasodilators will do that. Conditions like sepsis, which are caused by infection, will also decrease your afterload by lowering your mean arterial pressure. Now, if you fix obstructions, like you fix someone's aortic valve or you treat their hypertrophic cardiomyopathy, that's going to bring down afterload and increase the stroke volume. And then anything that decreases total peripheral resistance will decrease afterload. All right, the last variable that affects stroke volume is contractility, and you can think of this as the inotropic state of the heart, which is basically just the strength of the contraction. How strong is this heart? And this is independent of preload and afterload. So, we talk about how increasing preload will increase the force of contraction, but we're talking about how strong that heart is regardless of how much you're stretching it. And this is usually affected mostly by chemical and hormonal influences and regulated by the sympathetic nervous system. So you have beta 1 receptors on the heart that will increase how fast the heart's going, but will also increase how forceful the heart can contract. If you increase contractility, you're going to have a higher stroke volume. And so that's going to reduce your end systolic volume, right? And your end systolic volume is your end diastolic volume minus your stroke volume. So here's that cardiac output curve again with cardiac output on the y-axis, right atrial pressure and end diastolic volume on the x-axis, and the black line showing you normal. Makes sense that if you increase contractility, then you're going to increase cardiac output. If you decrease contractility, then you see that the cardiac output curve will shift down. And again, here's a pressure volume loop showing this relationship. So, the red loop is showing if you increase inotropy, if you make the heart beat stronger or contract stronger, you're going to have a larger stroke volume. And if you decrease inotropy, if you make the heart weaker, that's going to decrease the stroke volume. So anything that increases contractility will increase the stroke volume. Main things would be sympathetic nervous system stimulation, that fight or flight response. Your heart's going to be stronger, you're going to have a higher stroke volume. You can give medications that can do that. So inotropic medications like dobutamine, epinephrine, norepinephrine are going to increase your heart's contractility. There's also medications that increase intracellular calcium, which can improve the force of contraction. So one of those medications is digoxin. And then athletes who exercise a lot, their heart will undergo hypertrophy, get stronger to compensate for the higher needs of that individual. So decreasing contractility it will decrease your stroke volume. So these are medications that block sympathetic nervous system, like beta 1 receptor antagonists, also called beta blockers. Calcium channel blockers will do this. And then if a patient has congestive heart failure, they're going to have decreased contractility. So one more time, stroke volume is going to increase if you have increased preload, if you have decreased afterload, and if you have increased contractility. Now, another important variable that you need to know about is compliance, and you can think of compliance as the distensibility of a vessel, and you calculate compliance by change in volume over change in pressure. So as we increase volume, does the pressure go up or stay about the same? And if the pressure doesn't go up very much when you increase volume, then that is a very compliant vessel or ventricle. Now, a stiff ventricle has poor compliance because as you increase the volume of blood, pressure is going to go up. And so you can think of stiff arteries, stiff vessels, stiff ventricles as being poorly compliant. So you can plot changes in compliance on these same curves. So you might see like a pressure volume loop with these things, but basically just showing you that like the curve on the bottom with increased compliance, as you increase the volume to higher and higher volumes, you don't really see much of a change in pressure. Whereas in the top curve, when you decrease compliance, you're going to see much bigger changes in pressure for smaller changes in volume. All right, now let's talk about venous return. So this is the quantity of blood that flows from the veins to the right atrium each minute. And each peripheral tissue of the body controls its own local blood flow, and all that local tissue flow combines and returns by the way of the veins into the right atrium. So there are three main things that affect venous return: right atrial pressure, mean systemic filling pressure, and your total peripheral resistance, which is also referred to as systemic vascular resistance. So right atrial pressure is equal to central venous pressure because there's no obstructive valves that impede blood flow from the veins into the right atrium. So we can use right atrial pressure to approximate central venous pressure. It's normally going to be pretty low, 0 to 5 millimeters of mercury. And lower right atrial pressures are going to increase venous return because of the pressure gradient, right? So you don't want really high right atrial pressures for venous return. The lower the pressures, the easier it is for blood to return to the right atrium because of that pressure gradient. Now, mean systemic filling pressure is kind of a confusing concept, but when the heart stops pumping and your cardiac output is 0, so like you have like an arrhythmia, like ventricular fibrillation, or you have complete asystole, the heart is not contracting at all, the flow of blood everywhere is going to stop. And when there's no blood flow at all, the blood is still exerting pressure in the system, right, in the vessels, but it's going to equalize throughout the system. And that pressure is then called the mean systemic filling pressure. And so that mean systemic filling pressure is higher if you have higher blood volumes or if you have sympathetic stimulation. The mean systemic filling pressure is going to decrease with lower blood volumes or sympathetic inhibition. Now you can plot this relationship of mean systemic filling pressure on a venous return curve. Right, so here we have venous return on the y-axis and right atrial pressure on the x-axis. And if your normal line, this red line here, has a mean systemic filling pressure of 7, abbreviated as PSF, it's going to have a venous return of about 7 liters a minute. But the green line shows what happens if you increase mean systemic filling pressure from 7 to 14. So we've now doubled our mean systemic filling pressure. We've shifted the curve to the right and up, and now you're going to have a higher venous return because there's more blood in the system. Whereas if you decrease your mean systemic filling pressure from 7 to 3.5, like in the blue line, you're going to decrease your venous return because you have basically less blood in the system. And you will note that when the right atrial pressure equals the mean systemic filling pressure, there's no longer any blood flow because there's no pressure difference between the peripheral vessels and the right atrium. And as soon as the right atrial pressure drops below the mean systemic filling pressure, that's when you start to see an increase in venous return. So venous return curves shift right with increased volume and venous tone, and venous return curves shift to the left with decreased volume or venous tone. Now, the last variable that affects venous return is resistance. So if you increase total peripheral resistance, you're going to reduce venous return. And about 2/3 of resistance to venous return is determined by the resistance in the veins, and about 1/3 is affected by arteriolar and small artery resistance. So this is what a venous return curve looks like for changes in resistance. You see the red line is normal resistance, and if you decrease the resistance to 1/2 normal, then you get twice as much blood flow, which rotates the curve upward. So decreasing resistance is going to increase venous return. If you increase resistance to twice normal, which would be the green line, you'll get half as much venous return, and that's going to rotate the curve downward. When right atrial pressure rises to equal the mean systemic filling pressure, venous return goes to 0 no matter how much resistance there is. So this is why the curve does not shift with increasing or decreasing resistance, only the slope changes. So some physiology sickos figured out that you could plot cardiac output curves and venous return curves on the same graph, and that this is an excellent way to torture medical students. So you will see these types of graphs on exams like step 1 of the board. So it is important that you know how to interpret them. So your red line is your cardiac output. Your blue line is your venous return curve. And because cardiac output should equal venous return, where those two curves intersect is your normal equilibrium. Now, what if I increase someone's preload? What if I give them a blood transfusion or a bag of IV fluid? I've now filled up their tank, right? I have shifted their mean systemic filling pressure to the right because there's more volume in the tank. I've also increased their preload, right? And because I've increased their preload, that left ventricle is going to stretch more to accommodate that volume, and you're going to get a more forceful contraction and a higher stroke volume. So your cardiac output is going to go up. And so that's why we see when the curves change here at that point B, the new equilibrium is at a higher cardiac output when I increase preload. Now, what if I give somebody a vasodilator? Well, if you give someone a vasodilator, you're going to decrease their afterload. And when you decrease afterload, cardiac output goes up. You've also decreased total peripheral resistance. You've decreased venous resistance. And so venous return will also go up. And so this patient now, after you give them a vasodilator, is going to have a new equilibrium point at a higher cardiac output with a higher venous return. So that's what their new curve would look like. All right, now we're going to change gears a little bit and talk about myocardial ischemia. So myocardial ischemia is when you're not getting enough oxygen to the myocardial tissue. And that can be because of a supply problem or a demand problem. So typically your oxygen supply is going to increase if your demand increases. They should always be in perfect balance. Your myocardial oxygen supply is determined by how much oxygen is in the blood, and it's affected by coronary blood flow. Your myocardial oxygen demand is affected by wall stress, heart rate, and contractility. And if there's an imbalance here, like you have too much demand and your supply can't meet that demand, you're not going to get enough oxygen to your myocardium. That's going to cause ischemia. It could also be a supply problem where you have an obstruction in your coronary artery, so you're not getting enough blood flow to meet even normal demand, right? So anything that causes an imbalance here will cause ischemia. Okay, let's talk about coronary blood flow. So the heart is going to extract as much oxygen as possible from its blood supply. It's very efficient at doing that. So really the only way to increase oxygen delivery to the myocardium is to increase your blood flow. Blood flow is determined by Ohm's law, where flow is equal to change in pressure divided by resistance. So you can increase blood flow by having a larger pressure gradient or by decreasing resistance. Now, what are the major determinants of resistance? Well, those are described by this law, and it's very important to me that you know how to pronounce this law. It's Poiseuille's law. It's not Poiseuille's law. It's Poiseuille's law. And Poiseuille's law It says that resistance is directly proportional to the viscosity of blood and the length of the vessel, and inversely proportional to the radius of the vessel to the fourth power. So that small increases in radius will lead to a dramatic drop in resistance and increase in blood flow. So it's often called the fourth power law because it's really the radius that affects most of your blood flow. Viscosity of blood is important, but very small changes in radius of a blood vessel will drop the resistance and increase the blood flow. So the coronary arteries control their own blood flow, and that's determined by local metabolic factors, endothelium-derived substances, and neural innervation. So let's talk about some of those. One of them is adenosine. So during hypoxemia, ATP cannot be regenerated, and so you get an accumulation of ADP and AMP, and they get degraded to adenosine. And adenosine is going to bind to receptors on vascular smooth muscle, decrease calcium entry into the cells, and that leads to relaxation of the vessel, vasodilation. So you've increased the radius, that's going to increase blood flow because of the drop in resistance. Other metabolites that can act as vasodilators include lactate, acetate, hydrogen ions, and carbon dioxide. Endothelial factors like nitric oxide. This is a metabolite of arginine that causes smooth muscle relaxation. It's going to cause vasodilation by a cyclic GMP-dependent mechanism. So you're going to vasodilate, you're going to drop resistance and increase blood flow. Prostacyclins, a metabolite of arachidonic acid, they cause smooth muscle relaxation through vasodilation. This is through a cyclic AMP-dependent mechanism. And then you have the endothelium-derived hyperpolarizing factor, which helps relax neighboring smooth muscle cells, and endothelin-1, which is actually a vasoconstrictor. So it's going to do the opposite of these other endothelial factors. And then neurofactors like sympathetic receptors, you have your alpha adrenergic receptors are going to cause vasoconstriction. Beta 2 receptors, if you stimulate those, they cause vasodilation. Parasympathetic nervous system contribution is pretty minor here, but acetylcholine does stimulate the release of nitric oxide. Now it's important to remember that coronary blood flow occurs during diastole, and so systolic flow is actually impaired by the compression of the small coronary branches as they course through the contracting myocardium. So during diastole, the relaxed myocardium does not compress the coronary vasculature, and that's when you get blood flow through the coronaries. So your perfusion pressure is approximated by the aortic diastolic pressure. So we've talked about myocardial oxygen supply, which is mostly coronary blood flow. Now let's talk about myocardial oxygen demand, and you'll remember that that's determined by heart rate, contractility, and ventricular wall stress. So it makes sense with heart rate that if you have more beats, you're going to use up more ATP, so you're going to consume more oxygen. So increasing heart rate will increase myocardial oxygen demand. It also makes sense that if you're beating stronger, you're going to use more ATP, so you're going to need more oxygen. So if you increase contractility, like if you activate the sympathetic nervous system, you're going to increase your myocardial oxygen demand. And the last piece is ventricular wall stress. Now, ventricular wall stress is the tangential force acting on myocardial fibers that tends to pull them apart, and it's the energy that's expended to oppose that force. And so during diastole, ventricular wall stress is related to preload, right? Because preload is what's stretching those muscle fibers. And during systole, ventricular wall stress is related to afterload because that's the resistance that you're contracting against. So if you increase ventricular wall stress, it makes sense that you're going to consume more oxygen. Ventricular wall stress is defined by Laplace's law, where wall stress is directly proportional to pressure times radius divided by 2 times the wall thickness. So if you increase pressure, that's going to increase wall stress and increase your myocardial oxygen demand. Whereas if you decrease blood pressure, that will decrease your wall stress and therefore decrease your myocardial oxygen demand. If you increase the radius, like the circle on the left, that will also increase the wall stress. So patients that have a dilated left ventricle or a dilated cardiomyopathy will have increased wall stress, increased myocardial oxygen demand. And if you increase the thickness of a ventricle, so a thicker myocardium, you're actually going to have less wall stress because it's inversely related. And so a thicker myocardium is actually an adaptive response to increased wall stress, and so it will actually decrease your myocardial oxygen demand. So patients that have uncontrolled hypertension will develop thicker myocardium to reduce the amount of wall stress. All right, class. Nice work if you made it this far. Covered a lot of learning objectives. Hopefully it wasn't too painful, and we'll see you soon.